World Vision has used barrier analysis in more than 40 countries. A lot of this was done through WASH, but a lot of our health and nutrition staff have also done barrier analysis studies, especially in some of our grants programs. We plan to use barrier analysis as a way to better understand vaccine acceptance as we roll out COVID-19 vaccines. So the studies that World Vision and other agencies are conducting are based on barrier analysis, which is a rapid assessment formative research tool to identify the behavioral determinants associated with a particular behavior, such as using a mask regularly or COVID-19 vaccine acceptance. We do these studies in order to develop more effective behavior change messages and activities. Barrier analysis is based on the health belief model and the theory of reasoned action models. And a key feature is that you interview those doing a behavior, the doers, or intending to do a behavior, and compare their responses to those who are not, the non-doers or non-acceptors. This allows you to look for correlations between responses and the behavior, and in this case, vaccine acceptance, so you can better identify what is driving behavioral adoption. Barrier analysis has been used in more than 40% of lower and middle income countries. Analysis is done with a simple spreadsheet, and barrier analysis was used extensively during the Ebola outbreak, and World Vision is now using it to study the acceptance of COVID-19 vaccines, comparing responses from people that plan to get a COVID-19 vaccine with those who do not. I developed this tool about 30 years ago, and along with Bonnie Kittle, we popularized it amongst many INGOs, and UNICEF is now using it as well. And we believe this tool will be very helpful to our fields in helping to understand better vaccine acceptance. These are the main determinants that are explored in these studies, things like perceived social norms, whether you think that people important to you approve of the behavior, but also perceived severity, whether you think that COVID-19 is a dangerous disease or not. All of these are taught in the barrier analysis training. These are the main steps in barrier analysis. So first, a standard barrier analysis questionnaire, including both open-ended and closed-ended questions, is used. This has already been developed for COVID-19 vaccines, but it can be modified, adding questions that might be useful in a particular country or context. You then interview 45 vaccine acceptors, or doers, and 45 vaccine non-acceptors, or non-doers, either over the phone or in person. And with barrier analysis studies of staff and others with higher literacy, respondents can receive a link to fill out an online survey. The first questions identify COVID-19 vaccine acceptors and non-acceptors for interviewing. The remaining questions are based on 10 different behavioral determinants. Results are then tabulated by enumerators or program staff, and the tabulated results, like the number of acceptors and non-acceptors giving each response, are entered into an easy-to-use Microsoft Excel barrier analysis tabulation table, which generates findings, p-values, and associations with vaccine acceptance. We actually have set up one of these, the standard barrier analysis tabulation table, to exactly match the questionnaire that we're recommending you use, so that's available. Staff and then stakeholders use the findings on significant differences between acceptors and non-acceptors to create useful messages and activities that leverage the enablers and reduce the barriers to COVID-19 vaccination. And then they monitor indicators to track changes in those key determinants over time. This is what the questionnaire looks like. You'll see that some of these are open-ended, like if a vaccine were available to you in the coming month free of charge, what would be the advantages of getting the vaccine? And then you probe with what else to get all the responses. There's a similar question on negative consequences. And then there are also some closed-ended questions like the one below that. What portion of the people that you know do you think would get the vaccine? Would you say that most people would get it, about half would get it, or very few would get it? And then down below, you'll see the barrier analysis tabulation table. You only have to fill out the green cells in this with the sample size you used, usually 45 and 45, the estimated prevalence of behavior from any local studies that have been done in your country, and then the responses to each of the questions. And you'll notice that over there on the right, all of that is done automatically by the spreadsheet and helps interpret what the findings are from the data that you've entered.
So now that Marella has explained what barrier analysis is, I'll show you what we're finding through these VA studies. This table shows which determinants of COVID-19 vaccine acceptance were found to be important in the 6 barrier analysis studies that have been completed so far. And note that for perceived divine will, whether or not you think that God approves of the behavior, that was an important determinant in all of the countries. And in 2, rural Bangladesh and Kenya, it was highly associated with the decision to get a vaccine. Also note that while I will be focusing on a couple of these determinants, faith leaders can message on all of these determinants. They can ensure that people are getting accurate information and help to establish a social norm and be a model for others. So for example, perceived susceptibility, this is whether or not someone believes that they are likely to get the disease or problem or not, in this case COVID-19. And when that's low, people think that they're not at risk of getting COVID-19. They're usually less likely to want the vaccine. Faith leaders can help change that. In countries where we find non-acceptors are more likely to have low perceived susceptibility, faith leaders can talk with their congregations about how anyone can get COVID-19, and we all need to take precautions. Using Luke 13:4, where Jesus talks about the Tower of Siloam tragedy, for example, could come in useful for that. Here's what we found using the barrier analysis questions on faith and faith leaders in Myanmar, Dhaka, and Tanzania. So in Myanmar, we found that vaccine acceptors were 2.8 times more likely to say that God approves of them getting a COVID-19 vaccine, and 1.3 times more likely to say that they had a very high level of trust in COVID-19 vaccine information that is provided by religious leaders. We asked whether residents agreed or disagreed with the statement, whether I get COVID-19 or not is purely a matter of God's will or chance. The actions I take will have little bearing on whether or not I get COVID-19. And in Dhaka, and these studies were led by colleague Kaliman Bull, we found that acceptors were 1.2 times more likely to disagree a lot with that statement. That is, to believe what they did made a difference. Acceptors were also 1.3 times more likely to say that most other community and faith leaders would want them to get a COVID-19 vaccine. And in Tanzania, acceptors were 1.5 times more likely to say that God approves of their getting a COVID-19 vaccine, and also a whopping 14.7 times more likely to have a somewhat or very high level of trust in the COVID-19 vaccine info provided by religious leaders. Acceptors were also more than 18 times more likely to say that most other community and faith leaders would want them to get a COVID-19 vaccine. And here's what we found using the barrier analysis questions on faith and faith leaders in rural Bangladesh, India, and Kenya. In rural Bangladesh, we found that vaccine acceptors were 2.2 times more likely to say that Allah approves, 2.4 times more likely to say that they had a somewhat or very high level of trust in the COVID-19 vaccines info that religious leaders provide, and more than 13 times more likely to say that most other community and faith leaders would want them to get a COVID-19 vaccine. Non-acceptors, on the other hand, were more than 6.7 times more likely to say that they agreed a lot that getting COVID-19 was just a matter of God's will or chance. In India, acceptors were 3 times more likely to say that they believed God or Allah or the gods approved of their getting a COVID-19 vaccine. Non-acceptors were also 2.6 times more likely to say that they had a somewhat low level of trust in information that religious leaders provided on COVID-19 vaccines. And in Kenya, acceptors were 2.4 times more likely to say that they believed God approved of their getting a vaccine, and 4.4 times more likely to say that they had a very high level of trust in COVID-19 vaccines info from religious leaders. So how is World Vision using this information from these studies? Well, there are multiple ways. We're using them to inform stakeholders and policy through presentations and through thought leadership. For example, Dr. Robert Kanwagi was appointed after a competitive selection process to the COVAX Facility Demand Working Group, and he presents and leads meetings with them regularly. Robert and I have also presented to the UNICEF-led Africa and South and Southeast Asia COVID-19 demand task forces. And Dan, Robert, and I have presented to the Vaccine Confidence Project, the leading think tank on vaccine hesitancy. We were also successful in getting UNICEF to include barrier analysis in the African version of the Data for Action manual and requested that WHO do likewise at a global level. Robert was also asked by the WHO to coordinate the review of all of the Africa national deployment and vaccination plans, so he has been able to use this data and advocate for more barrier analysis studies through that role. Communication staff have put out numerous press releases and thought leadership pieces using some of this. For example, there's one on faith leaders must play a key role in COVID-19 vaccine rollout. Robert did one on think discovering vaccines is the hardest part, think again. And I wrote one on the beauty of truly listening. We are also in the process of publishing this evidence. We will be submitting a summary of 5 COVID-19 vaccine barrier analysis studies to a peer-reviewed journal. Adunya Kabedi and the TSO is leading on that work. And Robert and I will be co-authoring another partner's barrier analysis studies, the DACA one, for publication. Also, of course, we're going to use this information in our field offices. By knowing which determinants and specific responses are important, you can use that to develop activities and messages to confront each barrier and leverage each enabler. And faith leaders and community health workers can play a major role in that. For example, for Perceived Divine Will, field offices can use the forthcoming COVID-19 vaccines module of Channels of Hope and create sermon guides that can be used by faith leaders. Field offices can also have religious leaders promote the behavior in community meetings and through social or mass media. I've included the links here for the questionnaire that we use to look at the determinants of people being COVID-19 vaccine acceptors, but also another one we plan to use in the DRC soon to look at why some faith leaders plan to promote the COVID-19 vaccines within their congregations and others do not. And note that World Vision's faith and development staff collaborated with us on the development of that questionnaire. And lastly, a link where you can take the survey yourself, just for fun. Thanks.